we're sitting on top of decades of science that haven't been delivering the goods for us in terms of mental and behavioral health, but is giving us flat lines or decreasing lines instead of increasing lines. And some of what's behind it is racist and sexist and dirty. And so, if you see all that, let's push the reset button responsibly and begin to confront some of the problems we've got and see if we can find greater diversity in ways forward that I believe will involve practicing clinicians as the base and will be less focused on just the weird world and will be more focused on serving the people that we serve. That's my hope. That's my dedication. That's what I want to spend my life doing. And I appreciate the opportunity to speak again on your podcast because I know, and I love the name of your podcast, that there's some folks out there who are not willing to just be same old, and be satisfied with where we are. We shouldn't be satisfied with where we are. The world needs more from us than we are giving.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
We're developing actively new statistical methods, and we're showing how much better they do in predicting individual lives compared to the massive distortions that come through our traditional biostatistics. That's a geeky conversation to have in a podcast like this, but I can tell you that there are solutions in hand that at least don't violate your assumptions. And the ones you're using that you're taught is science violate their own assumptions. You can never recover from that. If you have a formula that doesn't meet its assumptions, you have a formula that's built on sand. And so that's what we've done. We've built these big structures and acting as if we know, and we're trying to freeze science in place. And the science we're freezing in place has been corrupted by things like eugenics and is insensitive to the use case to which we want to put the research we're doing.
yeah, I mean, I think it's invaded into societal groupthink as well. How often do you see a patient that comes to you and wants to be normal?
Well,
Whatever that means, my response is, well, you're not normal. You don't want to be normal. Oh, I just want to be fixed. I'm broken. No, you're not broken. You're part of a diverse system that requires people like you. I'm not discounting the problem that somebody is coming to see me for, but trying to break them out of this idea of being broken. There are characteristics that you possess that you have been taught by your society that are negative, that are actually, if utilized the right way, can be extremely important to the group. Go
this
ahead.
normal thing, like how normal is your fingerprint?
Not very normal.
Do you think your whole body, your history, your culture, your thoughts, your emotions, your memories, your sensations are less complex than your fingerprint? You're trying to put normal in there. If you take, and done it statistically, we played around with it. If you have like 6 variables and you say, okay, how many people are within one standard deviation of all 6? You keep adding a few things, you get to the point where there's one normal person and he lives in the Netherlands. I mean, it's just ridiculous. Our science comes out and says, here's the mean. Yeah, as if that's normal. Yeah, that's the norm. We call it the norm. Okay, how many people does that represent? We've got data sets where the answer is nobody. The thing that's in the journal that says it's like this, nobody does. You think that's impossible? It's not. Not only is it possible, it's common. And so if you kind of think it through, you realize, wait a minute, this thing is no. Okay, so how do I characterize your strengths and weaknesses or the things that serve you or don't serve you in such a way that I know what kind of changes you might want to focus on to get the goals that you want. That's great. It takes a whole different kind of frame, and it means pushing a reset button. And there are a few areas of science that were like that. Certain wings of developmental psychology have been like that. I came out of field behavior analysis that was like that, built on the idiographic data. They didn't know the stats, they didn't know how to really, but still, if you're interested really in the function of the brain, there's lots of neuro people who are like that because they realize if I just say, oh, this part of the brain connects to that part of the brain in this way, I can't really do the work because every brain is different. People show up commonly, apparently normally functioning people, and they have to get an fMRI or something, and they only have half a brain. One hemisphere never developed. They're absolutely walking around completely normal. Normal. There it is again. You almost can't say a sentence or a paragraph that's complex without appealing to the normal. Normal wasn't even in the English language until around the 1840s. That's how recent it was, but we came to worship it. Saturday Evening Post had a competition of who's the most normal female, and they had a statue of her called Norma, and they'd have international competition as who can be just like Norma. And it was darn hard to find anybody who's like Norma because it turns out that normal is almost never. And so, what are we going to do with diversity then? How are we going to understand it in a way that we can empower people? We need a different kind of science to do that. So, your worry about the standardization, I think, is a huge worry. We could delay what needs to come by 100 years if we do that. We could just do it by regulatory requirements. And I see this happening in dirty ways, and I'm a little suspicious because of the $1.5 trillion industry that's behind some of this when you get over in mental health. And I'll give you an example. And in Europe, if you have an app that you think might help with people with, let's say, depression or whatever, it has to go through a certification process that is the same as medications. It'll take you about at least $100,000 to do that. Guess who owns the apps? Guess who has the money to do that? And when you do it, you have to genuflect in front of the DSM or the ICD. What if the DSM or the ICD, we know it says right in the beginning, don't use this to pick treatment. It's not been validated to do that. It says it in writing. The DSM-5 work group was quite right and very honest about it. There's no sensitive and specific biomarkers. It's not known to have treatment utility. Okay, so in order to have an app where you can get people to use skills in Europe, you have to genuflect in front of that flawed system or you don't get to do it. Well, how about the next thing in order to have a self-help book? How about in order to be able to do a podcast? This is not very far away. It could happen. And in some countries, it basically has happened. What has not been able to be achieved by science is now being achieved by regulation, with politicians being encouraged by a $1.5 trillion industry that they have to because that's real science.
I fear that AI will be that next machine that tells us how to live and what to do and what the science and the standard is. We'll have to find another time to talk about that normal person and why they're from the Netherlands. We could probably do a whole hour on that. I'm curious as to why.
I'm still trying to find him. I know he's out there somewhere.
Nasir Gami has been on the podcast before. He's a psychiatrist and he's very, very critical of how DSM is not a valid scientific evidence-based tool for diagnosis. He makes the argument that based on the course of illness over time, based on the genetic factors in the family history, and based on response to medications, that there's really only a half dozen to a dozen valid diagnoses. Now, diagnoses are, to me, they're important. They're clusters. They're not, one box, but rather a box that allows kind of spilling out over each side of it, if that's a symbolically helpful. I could understand that some people may take what you say about diagnosing. And by the way, I know this, I can say this on your behalf. You're not anti-medication. I'm not anti-medication. Obviously, I think both of us would agree that we are utilizing way too much medication in our treatments, creating this idea that there's some standardized approach to mental health, to human beings, and all the different components of what we struggle with. Where do you find that middle ground in what is valid? How can diagnoses be helpful versus, obviously, we've talked about how they can be really detrimental societally, but where is that middle ground?
I think the middle ground is practicality. Let's just hang on to treatment utility. If you have a label or a category that's being used to organize treatment and not just to sort of get a insurance provider to agree to pay or not, or to have some sort of nomenclature to talk about things. Yeah, it's having a nomenclature to talk about things is fine, but let's not let that tail wag the dog. I mean, if I decided, okay, well, I'll just measure how long your nose is or the shape of your skull. We went through that. We actually did that. That was a form of diagnosis. Nobody does that now. We'll give you a nomenclature. Yeah, but it's not a useful one. Okay, well, how do we know that it's useful? Useful for what? Well, you say, how about useful
It's
for?
what the science said at the time, too.
It
I
is
just want to
exactly
point
what it
out
said. It's exactly what it said. And if we say instead, okay, we want a nomenclature that suggests what might be most helpful, and you get better outcomes when you think about it that way. It's called treatment utility. And I wrote an article on that, still very well cited back in the 1980s, about that was the ultimate purpose of assessment. And I laid out a bunch of designs you could use to test the treatment utility of assessment. And to this day, there's just a handful of studies that have ever been able to get there. What if we just push the reset button and we say, okay, let's model in people over time and look at what they do. And then look at what lifts them up or pushes them down one person at a time. You can model that statistically. And if we find, and there's 3 randomized trials underway right now that have been funded and are underway, others that are coming, that when you focus on what the within person information says would be helpful versus what it says would be inert, you get better outcomes. We have 3 or 4 pieces of data that fit with that. Here's one little piece. If you're a practitioner listening to this, if you simply tell to practitioners, here's a protocol that's been helpful with people who have these kind of characteristics, traditional psych diagnosis, use what's useful and leave the rest for this person. 2 meta-analyses, really well done. One that I was involved with young people and adolescents, one with adults, have shown the same effect size. Just that, take the chains off, you get about a 0.25 jump in the standard deviation of the overall effect size on Cohen's d. Now we're doing studies to say, okay, now if you target the processes of change that lift up or push down or are inert within each person, what will happen? And we have a few studies showing that, but not big ones. That's helpful. So the big ones are coming. So let's focus on treatment utility. Let's model the individual persons that we've got. I think if we do those 2 things, we can have a form of diagnosis that has been in empirical psychosocial approaches to mental and behavioral health issues for a long time. It's called functional analysis. And case conceptualization is important. Functional analysis can be helpful, but to get to it, we have to measure function over time within the person. Look, take a principle like reinforcement. That's a function. Yeah, if I say, okay, reinforcement works. So Ethan, here's the idea. What I'm going to do, I'm going to follow you around. And every time you do something I like, I'm going to grab you and shove an M&M down your throat. You think that's going to work? The answer would be no. Why not? Because it doesn't fit you. The concept of reinforcement doesn't mean, that's a function. It doesn't mean that, yeah, for some kids under some circumstances to some degree, and and you got to be careful about it because there's intrinsic reinforcers, not that intrinsic. There's a whole science of it. You don't just sort of turn that into a cartoon. We've turned it into a cartoon. And we're doing it with how we use medications without really looking and having the data for a personalized psychiatry where you actually know how that particular chemical is likely to land for that particular person as part of a dynamical system that includes things that are influenceable by psychosocial methods. So it is a complex way to think because there's lots of variables, your individuality, your fingerprint. But we already have some signals that say it could be helpful in personalization. And we have some signals now in the lab and so forth that we're able to center in on some of the particular functions that are most important. I'll give you an example. We are using right now a machine learning method that has never been used the way we're using it to simply sort good days and bad days into a decision tree using a random forest procedure and a correction to make sure that you don't overfit. Overfit gets geeky, but let me just say what the problem is. One reason why stats didn't embrace longitudinal data and idiographic data is that it's hard to model at the time. Remember, they were doing all these formulas by hand. And things like autocorrelation, whatever you're doing yesterday, you're likely to do today, is hard to correct for, and so forth. So we saw it in things like factor analysis, where instead of looking across a whole bunch of people at a given point in time, you could look within a person over time. It exists. It's called p-factor analysis. They fought over it, but it was really hard to do, and they weren't sure kind of how to do it. Well, now we've gone back. Now that we're looking longitudinally, and we're taking some of these tools that are out there that are kind of cool, like random forests and decision trees, and we can sort person by person, good day, bad day. This is the most important of all the processes you've got that bump you in the direction of a good day. Why? And you can have other branches, like even on the good days, can you have super good days or kind of good days on the bad days? So you can filter out the complexity back to the fingerprint analogy. Yeah, it's complex. There's lots of things here, but that little ridge for you predicts this. And do you really care if it predicts it for you, but not for somebody else, if you're the one who's needing treatment? When my brother developed cancer, he ran, he didn't walk, he's a physician, over to UCSF to get experts who could look at his particular tumor and characterize it genetically, epigenetically, etc. A lot of physicians know that one size fits all doesn't work. That's why we call our statistical team one size fits none. This is a solvable problem. But if you're going to lock down science and you're going to say only this is true, and here you've got a science in the case of mental health where I'm unaware of anything over the last 40 years in the psychosocial area, we're getting bigger and bigger effect sizes. I'm unaware of even one. So we're not doing a better job. It's going in the opposite direction almost everywhere you look. You mentioned that. Let's push the reset button, put in front of us treatment utility. Can you give me a diagnosis? I'm fine with that. A case conceptualization, a functional analysis of that particular person that tells me as a provider what is the best bet. If you can't do that, why should I listen to you?
Yeah, and you're involved with a new app, Psych, which you did not ask me to plug here or anything like
Well,
that.
thank
But
you for the plug.
what I got from that is that you're trying to standardize the approach within each individual
Right.
by accumulating data on the individual from the individual over time so that when they get stuck, when they have a problem emerge, you have a targeted approach to what you're doing that can help them out of that specific problem based on their data.
Exactly. And so, yeah, what's in PsychFlex is another app called MindGrapher that is inside of a not-for-profit that I'm president of, the Institute for Better Health. Why? Because we dare not make the mistake of allowing data on individual response to go into the hands of Apple and Google, who will sell it to big pharma in an instant. And so we have to wall it off and have a world-class panel of scientists who are protecting the database. We have 600,000 data points already in it, and it's growing every day. But that's in a not-for-profit. You can't buy us out. Then in the app, that has to be for profit because you have to constantly update the dang things. We put more than $1.5 million into the tech, and more is being flowing in, and it just has to because, and we haven't made a nickel, by the way, because it's very expensive to do, and it's a dream. And then when you get people to share what's going on with them over time and use some of the tools that we've now developed, it suggests that these processes are most important. You can support reaching out into the person's 24/7 world by, yes, have your session, let's say 1 hour a week. Well, that's 1 out of 168. What about the other 167? You can, with a finger swipe, send them little nudges and bumps, exercises, mindfulness exercises, songs, funny things, PDFs that will help with the particular core issue that you've identified by really looking at them as if their world is what matters and they're not an error term in an aggregation. And the error term is the variation within the person over time. Some of that is due to error, random factors. And that is the bane of it. That's, I was mentioning the complexity. The other one, if I'm going to be kind to how we ended up in this thing, everybody does this. If you have a special day that's especially good or especially bad, you sometimes for months, weeks, years, or the rest of your life, generalize it. You probably have had clients say things like, I can't eat broccoli. It gives me a panic attack because they ate broccoli and they had a panic attack. And okay, well, that happened once, but it's really, really unlikely it had any freaking thing to do with your panic attack. But we're evolutionarily prepared to do that because it's so important for us to survive, even so. What you do when you have idiographic data is you have to control for that. It's called overfitting. And we have that Baruda method I mentioned. What Baruda does is it does a random forest within the data stream. You don't need to understand what that is, but it's a wonderful statistical tool. Distribution free, interactions can be modeled. What Baruda does is that for every variable you're interested in, to say, does this predict outcomes for that person? You create a shadow variable that is the same data scrambled. Why would that matter? If there's outlier days, and that's why it looks like this is an important variable. When you scramble it, it's no longer going to predict at all. You want to make sure that it no longer predicts and that this model here always beats all the scrambled data on all the processes that you're interested in. Plus, if it's the one you're going to focus on, beats all of the processes in the native way. It's essentially like a really, really conservative correction. In stat, we call it a Bonferroni correction. So it basically doesn't lie. It says to the clinician, this is important, it's freaking important. Now, if you're a model builder and you really want to know, is my variable really important? It's not so good because it'll make type 2 errors. It'll be so conservative, it'll say, I don't think it works. And maybe it does help. But that's not what clinicians need. They need, just don't lie to me. Tell me what's important. Okay, here's what. So it's just one of about 5 statistical tools that we're putting into MindGrapher, which is the not-for-profit that's plugged into PsychFlex so that when you see it, it's something you can extend. And if you know that your client, let's say when he goes home for Thanksgiving dinner, is going to have Aunt Mabel criticizing him because he's gay, and that when that happens, he gets emotionally avoidant. And when that happens, next thing you know, he's withdrawing from people, and here he can't even be in the room with his family. Before you open that door, you might want to do this little 60-second mindfulness exercise that works on your emotional openness of what happens when you're criticized. We can follow our clients now into their 24/7 world. And the way that I say it to clients, when you look at how things fit together, and we have a tool that helps them start with how they think everything fits together with a little mapping tool called the Personalized Life Assessment Network. And they say, I think when this happens and this happens and this happens, okay, that's probably what's going on, what you do with a clinical interview. Now I say, but you probably forgot some stuff. There might be some stuff important there that are lifting you up or pushing you down that you don't even notice. If you had a good friend you could trust who could follow you around magically and watch you for a month and see whether or not these things you think are related are really related, would you want to know about that? If he'll never lie, he'll never forget, he's not going to share your data with anybody, would you be interested? Say, yeah. I say, okay, I nominate you as your best friend. And all you got to do, we'll give you a little ping once or twice a day. It'll take you 3 minutes. Answer a few questions. Let's look at the questions. You don't understand the questions, we'll change them. You want questions worded in your own way? We'll put them in. We've figured out the science of how to, you can use items in your own words and they're still scientifically valid. That's a big claim, but I believe I can prove it. So psychometrics, I think, has been forcing us into the one-size-fits-all box, which basically means white, educated, industrialized, rich, and democratic, and the rest of the world need not apply. If instead we sort of go into the grit and grain of that person's life and we ask them to be their best friend by just allowing their own data to go into a fully protected GDPR, HIPAA, fully protected, de-identified database that allows us to say, this is what's most important, and tells the clinician, target that and see what happens. I have a dream that this app, if we can get it to work, will allow a clinician to push a button and it will analyze that using world-class idiographic stats. And to push another button that'll write the freaking results section for you. What would happen if we had 10,000 multiple baselines or case studies built on the clinical base of what people actually see and what happens when you work with your clients instead of these one-size-fits-all statistics that only, big grants can possibly give you, when that means it only comes from a few countries in the world on only a few topics filtered through normal science in a way that you're talking about. You try to get your ideas funded, Ethan, inside big. Some of the ideas you've already expressed, I can tell you, NIMH ain't not going to fund it.
Not a chance. I don't think I'm going to land any jobs anytime soon at academic institutions either with the things that I talk about. Again, AI terrifies me in mental health because I think it's going to spit out answers that try to generalize. And you're proposing basically an individualized AI, a form of intelligence that will document and then analyze how you are in your day-to-day life and offer recommendations to decrease the distress that you experience based on how it understands you.
And then we may be able to cluster. I would like to know nomothetic science. I do want general laws. But you take something like reinforcement, it was not discovered by a group design, so-called by aggregate design. It was following individual organisms and altering consequences. And here's this function over and over and over and over and over and over. And finally, okay, it's generalized. And there's a lot of information about how reinforcement works. And that's the way the information was developed. Different schedules of reinforcement under different conditions of motivation, etc. And to this day, if you had to say, what are the biopsychosocial processes that are most robust? Well, I'll stick to the psychosocial ones. You're going to be using things, like reinforcement learning or exposure or things like that were discovered from the animal labs. Now we're not non-human animals, we're human animals. And that means we're speaking. It's way more complex. Language changes a lot, and that's been a bigger chunk of my career of trying to figure out why that is. Okay, great. We're going to have to model it differently, but let's do the same thing. Every voice matters. If you're not measuring and modeling, you're not listening. And if you're not personalizing, you're not treating. If we just have that set, every clinician could be an evidence-based clinician in a different way, not the one size fits all, follow the rule book, normal science says it's so, but no, work with your population, with your clients, and let them teach you how to be even better with them, but do it one precious person, couple, or family at a time. And that generalization then, and we have studies now where we've discovered clusters of people who are hidden. Seems like Horton Hears a Who. They're tight little groups of like 1 out of 12 people do this way. You put them in an aggregate design, they're just error terms. You model each person before you share any data. And here's this, oh, they're kind of similar. And we just published a recent one that we're calling them the Stoics, of people who, when things get stressful, they double down on values-based action. But the values-based action doesn't make them happy. What makes them happy is the social connections they have. But boy, do you need them in a group, because when things get stressful, they don't say, oh shit, I'm right. No, they focus on their values and they work even harder.
Gami, wrote an entire book about how leaders who would kind of fall on that bipolar spectrum or have, bipolarity are really, really good for us in times of crisis. And they're kind of shitty leaders during times of little stress and economic prosperity. It also speaks to Kay Jamison's work, the famous psychologist who struggled with bipolarity herself and trying to find that yang to the yin of negative associations with bipolarity. That I think it was something like 40% of England's poet laureates met criteria. I mean, the rates of PTSD in these elite athletes, if it doesn't break you, then it really can make you. If you always carry around this feeling like I am not good enough, that may be based in the trauma of experiences you've had in the past with those primary authority figures, well, you may always feel like that, even when you're at the pinnacle of success. That feeling stays with you, but it drives you. It drives you to want to overcome, to want to garner that respect. I know that feeling all too well, even though that conscious part of me can list off my accomplishments and my accolades and why I'm good enough. That feeling still is there. ACT and some other interventions in my life helped me to make room for that feeling, to let it exist, and that it doesn't have to dictate who I consciously think I am. And then one of my favorite examples, my wife and I were laying in bed one night, and I was telling her about a patient of mine with autism. And it just dawned on me as an evolutionary, theorist. I said, gosh, I bet you some of these individuals way back in the day, their ability to tell a story verbatim is so much better than somebody who, you may call neurotypical in this world.
Right.
Um, there are reasons why we have this diversity. When you were given this talk at the ACT boot camp in Denver in May of this year, I came out at one time. As I'm walking out, somebody else was walking in. They were pissed, and I didn't understand exactly why. It led me to kind of this question. How do you think people might misinterpret or misunderstand the message that you are delivering?
Don't usually see people actually pissed, but they're a little disoriented sometimes. I have deliberately held back a bit on some of the challenging things we're finding out about syndromal diagnosis and about our standard biostats and things of that kind, because people need a solution. They need to know that I'm not just saying that these things are real problems, but they're problems we can solve. If somebody has really been pretty much locked into thinking of their career only in terms of a particular diagnosis, and pick anyone and plop it in. And here I'm saying, some of these diagnoses have a dirty history, number one. Number two, they don't capture that much about what we really need to do, and we go more in a more personalized way. Well, if you're a researcher or you have your own clinic, or maybe the freaking name of your clinic even has the disorder in there, we've taught the whole world to think this way. And if we broaden it out, the kitchen table conversations 150 years after Galton are very full of things that he would be happy about. Oh, my child is gifted and talented. Oh my God, that's so wonderful. Yeah, that's fine, but being up on a particular edge of the bell curve like that means there's other conversations. Oh, my child's in special ed. Oh my God, look, don't sell people short. You don't know, and don't say this is the anointed. I don't think I did it at this boot camp, but I sometimes do. I show the picture of my son getting his second black belt and then tell the story that he was undiagnosably weak at age 3.5, and we were told the kind thing to do is never let him participate in any group sports because he's always going to be awful. It's a genetic disorder, and the only thing that you could do is just get him into something like, oh, an exercise class or martial arts, so at least he, has some exercise with his body. I mean, he was so weak he couldn't hold a knife and fork, he couldn't write with a pencil, he couldn't hang on monkey bars. Yeah, and when 10 years later, being in martial arts only and having his dad not even teach him how to catch a ball because I thought that was the good father thing to do. Because again, he'd be tempted to be part of want to play on a baseball team, and he couldn't. He just wasn't able to function physically. So I was told, I got him in there with a Olympic level coach, his second mother almost, Michelle Weaver, who had worked with him for 10 years in the martial arts class. This guy, Max McManus, who helped David Wise win 2 gold medals and 1 silver medal in half pipe skiing. Within a month, he was 25% stronger. And I got so mad when I saw that, that here I was stupid enough to believe, based on statistics, that the pediatrician and the physical therapist applying a table with normative numbers in it knew the future of my son. No, you don't know that future. That would only be true if these statistical models were ergodic. That's the fancy way to say it. It would only be true if knowing where you're on a bell curve determines your future. It doesn't. It is a snapshot of where you are, and what determines your future is what you do in that future. And does that mean that everybody can be everything? No, it doesn't mean that. I'm not saying somebody with an IQ of 30 can have an IQ of 130. But the idea that IQ is set, that's Galton. And it's a lie. And it's a corrupt lie. I mean, they literally, read The Children of Davenport when they first discovered in the Iowa Child Research Center that with kindness and stimulation, children of people who were at the time called imbeciles, that was the technical term at the time. I already used the term in Buck versus Bell in the Supreme Court decision, could improve their IQ by 25 points or so quite consistently without even knowing exactly how to do it. It was so threatening to the Terman at Stanford from the Stanford Binet, threatened to out the director of the Child Family Research Center in Iowa as being gay, which apparently he was, if he didn't suppress the data. You know, we're sitting on top of decades of science that haven't been delivering the goods for us in terms of mental and behavioral health, but is giving us flat lines or decreasing lines instead of increasing lines. And some of what's behind it is racist and sexist and dirty. And so, if you see all that, let's push the reset button responsibly and begin to confront some of the problems we've got and see if we can find greater diversity in ways forward that I believe will involve practicing clinicians as the base and will be less focused on just the weird world and will be more focused on serving the people that we serve. That's my hope. That's my dedication. That's what I want to spend my life doing. And I appreciate the opportunity to speak again on your podcast because I know, and I love the name of your podcast, that there's some folks out there who are not willing to just be same old, and be satisfied with where we are. We shouldn't be satisfied with where we are. The world needs more from us than we are giving.
And I just want to point out the compassion that you showed for your own grandfather and his story, that he was getting bad information. And there's a lot of other people out there getting bad information and running with it. And we have compassion for those people. We ask that people would open their eyes to the possibilities of what this historical information signifies in today's world. To add to what you said about your son, you know, the outcome, the expectation, the hope, in some ways, it's totally irrelevant. It doesn't matter because you can pursue your desired outcome and the process that would get you there, like him going to all of those martial arts classes and working on his physique. It doesn't matter. We get so caught up as individuals on whether or not we're going to reach our goal. And there's so many factors that go into that. But regardless of whether or not he had reached all of his goals or you or I reach all of our goals, it's so damn important to put time, energy, and effort into moving towards the things that we care about.
Yeah,
That's
I
what
very
it's
much
about.
agree. I much agree. And my son did get his black belt. A second black belt became the main teacher in the dojo and so forth. And he's frighteningly strong now. He had to work twice as hard as other kids to get there. But to extend what you just said, you know, he always just loved basketball and he's working on basketball. He's still not great as basketball, but he good enough. He can now play. He's at Purdue on the intramural teams and come in and spend some good minutes and hit a few three-pointers and he just loves doing it. And no, he's not going to be on the NBA, but neither are you or like me, and you can play. So one of the downsides of this is that there's kind of a cultural thing. You don't meet, not even your goals, you don't meet these goals. You are a failure. No, I mean, you can aspire and work and have fun and prosper at all levels of achievement and so forth. Achievement is not this one size fits all thing. And my gardener has a hell of a lot of wisdom. I love talking to him because of that. But you can easily walk by and in your own mind categorize people in such a way that you're really not uplifted by the people who are all around you, and you cut yourself off from things like, oh, I'm not good at that. You want to just say, so you want to come up here and sing with me? Oh, I'm not a good singer. You want to come up and dance? Oh, I'm not a good dancer. Or like there's so many fun things that are out there to do that we're not good at, but it's good to be doing. We've put something loose in the world of this way of thinking, normal and abnormal and good, bad, and indifferent, that is suffocating people instead of empowering people. And I think, psychiatry, psychology, etc., has had a role in that happening in the first place. That's why we had talked about that. They can have a big role in solving this and creating a culture that is more an empowerment culture than a categorization and anointing culture.
Yeah. So to summarize the discussion today, very, very succinctly, treat the individual, don't treat the diagnosis. And for
Yep.
God's sake, nobody's ever not had positive emotional release or cathartic release when they're singing and dancing.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
If you need help like this guy, call your own doctor.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.